Okay, so here we are. We finally arrived at talking about respiratory disorders, pathologies, whatnot. So let's just make sure that we're familiar with identifying respiratory distress. Oh, no. Do that. Okay. Good deal. All right, so let's talk about respiratory distress here. So what kinds of things can indicate that somebody's having distress or difficulty breathing, right? Nasal flaring, intercostal retractions, tachypnea, okay, tracheal tugging, or tracheal shifting as well, cyanosis, pursed lips, accessory muscle use, and just in general. Different patterns, irregular respiratory patterns, inadequate rate and depth, abnormal positioning like tripoding, tripod position, pursed lips, right? Elevated end-tidal CO2 with that classic shark fin pattern that points toward obstructive pathology, changes in your pulse oximetry, anxiety and altered level of consciousness can also be very early signs, right, of something going on, all right? Altered mental status going into that. Wheezes, crackles, patient tells you they have dyspnea, all right? It's a whole bunch of things. So that tells you that somebody has respiratory distress. Is that stuff that, anything new there? No, not really. So, in addition to that, there's also this concept known as airway compromise. This is where the airway itself is compromised and the ability to get air from the upper airway to the lower airway is compromised. That's what we mean by airway compromise. And so what kinds of things can tell you that you have a potentially compromised airway? Well, obviously snoring is a big one, right? What typically causes snoring? The tongue, right? Stridor, right? Stridor tends to be the result of supra or above the glottic edema, right? Swelling. Can also be the result of a mass, like a tumor, or even an abscess. You can get different abscesses like a paratonsillar abscess or a pharyngeal abscess, or even a dental abscess, a tooth abscess, can then involve tissues of the airways, and that's something known as Fournier's or Fourier's gangrene, which is potentially life-threatening. Unilateral wheezing. Okay, generally wheezing is bilateral, right? When we hear it. What would unilateral wheezing point toward? Yeah, it does mean, does mean one-sided. You're on the right track. Yeah, generally it means a foreign body. Yeah, you want to be worried about a foreign body obstruction when you have a unilateral wheeze. Secretion management, right? Are they drooling all over the place? Are they not able to maintain and manage their own secretions? Right? Lots and lots of crackles. You guys have heard of the term fulminant pulmonary edema or fulminating pulmonary edema. Did you guys learn about that in cardiology a little bit? What is that? What is fulminating pulmonary edema? Well, CHF patients may develop that, but flash pulmonary edema can cause it as well. But fulminating pulmonary edema is a sudden, severe onset pulmonary edema where they've got white frothy sputum coming out all over the place, right? They've got fluid literally coming out of their airway. It's white, it's frothy, sometimes it's blood tinged, right? And so their airways are just filling up with fluid that's basically leaking into the lungs from the circulatory system. Good. Edema, right? If they have some sort of mass that develops. Angioedema, what's angioedema? Swelling due to the vessels, right? And that's often the tongue and soft tissues of the airways. What are some primary causes of angioedema? Anaphylaxis is a big one, right? So there are immune causes. What is a medication cause? There is a specific class of medications that cause this in a small percentage of patients, and you guys need to know this. This is important to know. Because you cannot treat this effectively. If they develop angioedema from this class of drugs, okay, you cannot treat them like anaphylaxis. They will not respond. This is not an antigen-antibody, or your standard antigen-antibody kind of reaction. So you give them epinephrine like you would an anaphylaxis patient, you're going to increase their heart rate, but you are not going to treat that angioedema. I want you guys to know this because this is a very common class of medications that lots of people take for congestive heart failure, for hypertension, following myocardial infarction to prevent, not beta blockers, not calcium channel blockers, not digoxin, no. I think it even talks about it in the textbook specifically. There's even a picture of it and it talks about it. Because I know you guys have all done your reading, haven't you? Yeah. Yeah. Yeah, I wanna emphasize this point with you guys.
Acetaminophen?
Huh?
Acetaminophen?
Boy, that's pretty rare.
So ibuprofen, aspirin, and acetaminophen are the PEH.
So yeah, ibuprofen and aspirin, yes. NSAIDs can cause not necessarily angioedema unless they have a true allergic reaction to it, and then that's anaphylaxis. But they can cause problems with asthma exacerbations. But this is true angioedema. The tongue swells up, I mean, and they can lose their airway. It can be so severe.
It just says some medications can cause it.
Oh, it doesn't say specifically what? Oh, goodness. Okay. Let me just go ahead and throw it at you guys.
ACE inhibitors.
Yes. Angiotensin converting enzyme inhibitors, ACE inhibitors, yeah. Right, this is a well-documented, well-known side effect. It's fairly rare, but when it does happen, it's a doozy, and it's difficult to treat, right? ACE inhibitors can cause other, like coughing, dry cough.
How would you treat that?
You can't. You can't. And you're going to look at that and you're going to go, oh, they're having an anaphylactic reaction. But if this is due to ACE inhibitors, you give them epinephrine, you're going to increase their heart rate, you're going to increase their blood. You're going to cause all the side effects of epinephrine, but you're not going to have any of the benefits.
So if you see angioedema, you really need to get a medical?
You need to, yeah, you get a good history, try to figure out what the cause is, because it's not always anaphylaxis. Yeah. Yeah, so these patients would need rapid transport, and if they lose their airway, you might need to do a surgical option, right? Because you're not going to be able to get a supraglottic airway into someone like this, so this may be a patient where you have to do a surgical option. Is that bad? Okay. What's trismus again? Good, the masseter muscle spasms, shuts the jaw. And of course, trauma can compromise the airway as well. Okay, so we have this respiratory distress concept, right? And that's all of these signs and symptoms indicating that there is something wrong with the respiratory system, right? There's some problem. Respiratory failure is when the respiratory system fails to meet the body's demands. And we've talked about this already, but you have three general types. You have failure to oxygenate, failure to ventilate, and then you have mixed respiratory failure on top of that. So far, so good? All right. So what are the principles of managing pulmonary problems? Good airway positioning, protecting them, and suctioning them. First and foremost, right? Position your patient appropriately, protect their airway, and suction their airway out if needed, right? And then we can look at supplemental oxygen with respiratory distress or complaints of dyspnea, and we titrate the amount of oxygen to what's going on to the patient, right? All right. If you suspect hypoxia, give them oxygen. Never withhold oxygen if it's indicated, and we've already had a discussion about the hypoxic drive and how it's often overstated. So we won't belabor that point. Okay, so moving right along. So now what I want to do is I want to talk about a very common problem that we run into, and that is pneumonia. What is pneumonia?
Infection of the lung that involves consolidation in the alveoli.
Wow. Wow. Yeah.
You just read.
I'm just blown away. Yeah. So pneumonia is an infection of the lung. Okay, so it involves the lower airways, right? And it results in consolidation. What's consolidation? What does it mean to consolidate? Like put things together, right? So consolidation is a collection of stuff, right? Is a collection of infection, basically, bacteria, debris, pus, that kind of stuff, within the alveoli, okay? This may be viral in some cases, bacterial or fungal. It's often bacterial. And there are three general types. There's something known as CAP, or community-acquired pneumonia, okay? And community-acquired pneumonia, or CAP, is pneumonia that you get out in the community away from the hospital, all right? There's also something known as healthcare-acquired pneumonia, and a subset of that is something known as VAP, or ventilator-associated pneumonia, okay? And then there is, of course, something known as aspiration pneumonia, or pneumonitis, which results from the aspiration of gastric contents, okay? And each of these are a little different. So when we talk about community-acquired pneumonia, community-acquired pneumonias tend to be a little easier to treat. Why do you think they're easier to treat than healthcare-acquired and ventilator-associated pneumonias?
Because they have all the immunity or whatever. You're in the
Drug resistance, yes. Healthcare-acquired pneumonias tend to be highly drug resistant, much more difficult to treat. And there are very different treatment considerations for the different types of pneumonia. So history is important here, right? Finding out what was going on with this patient. You know, where were they when they got sick? And then aspiration. If somebody aspirates, you always want to think about stroke, right? Is this a status post-stroke patient, right? Somebody who's not protecting their airway, not able to swallow effectively, all right? So what's the history and physical exam for someone who has pneumonia? Well, typically they develop a fever, right? Elevated temperature. They're going to have a cough. They often have crackles. And typically what we see are the lower lobes get involved first. Pneumonia tends to start in the lower lobes, okay? Now, if somebody has a right upper lobe pneumonia, okay, that should cue you in to think about aspiration, right? Okay, but generally it starts in the lower lobes, and then as it spreads, it'll spread into the upper lobes if it gets worse. They can develop abdominal pain, myalgia. That just means muscle pain, right? You guys probably experience this, aches all over. Chills. The sputum that they cough up may be green, black, or brown, okay? Yellow sputum may or may not be an infection. Yellow sputum means that there's inflammation going on. In some chronic diseases, like COPD, for example, forms of COPD will cause yellow sputum, and that does not necessarily mean infection, but it could, all right? General malaise, all right? What kinds of patients are at higher risk for pneumonia? Anybody who's immunocompromised, right? So cancer, if they've had an organ or tissue transplant, and they're anti-rejection drugs, because what anti-rejection drugs do, they suppress the immune response, right? And people that have had transplants tend to be more prone to developing cancer. Why? Why are they more prone to developing cancer? Why do we see higher incidences of cancer in transplant patients?
blood cells, something with blood cells in the.
It's really easy if you think about it. What do we do to somebody who's had an organ transplanted? What kinds of drugs do we give them? We give them drugs that suppress their immune system, right? So when you suppress the immune system can't do what?
Fight the cancer.
Can't get rid of cancer cells, right? Every single one of us has had cancer. We've all had cancer. We'll have it multiple times in our lives. Multiple times. And generally, okay, your immune system can fight those cancer cells, get rid of them, and clear it. And sometimes it doesn't, right? So, yeah. HIV as well, as extremes of age, traumas and surgeries, and being intubated. Being intubated places your patient at very high risk, having advanced airway, and very high risk for pneumonia. So the goal of intubation is extubation. Seriously, is to get that tube out as soon as we possibly can. Get them breathing on their own, get them coughing and taking deep breaths, clearing their own airway, and get them the hell out of the hospital. And some people, I've run into some people like, oh, you're just worried about money, and that's why you want to get rid of patients as soon as possible from the hospital. It saves money. Well, yes, it does save money, but it saves patients, right? Because we don't want them to get a hospital or healthcare-acquired infection. If you're going to get an infection, it's generally much better if you get that infection out in the community, you know, at your home or wherever, than in a healthcare facility. Okay.
Isn't it if you are intubated, the longer that you're intubated, the harder it is to come off?
In some cases, yes. It can be harder to extubate. Particularly patients with underlying lung disease like COPD can be extremely difficult to extubate them, and oftentimes that leads to trachs, right? If you have a COPD patient and you intubate them, can't get them off the ventilator, and you eventually go to a trach, and then they have a trach for the rest of their life. Yeah, pretty common. Yep, absolutely. Okay, so what's general treatment for pneumonia? Well, supportive care. And what do I mean by supportive care? That's that IV, O2, monitor, get a history, right? All those things, right? IV therapy and fluid resuscitation as needed, right? If they have a fever and they're breathing fast, they may be getting rid of a lot of water. They may be very dehydrated. So rehydrating them with fluids. Give them oxygen if they need it. Beta agonists, only if wheezing's present, right? Beta agonists like albuterol will not do anything for pneumonia. You do not have beta receptors in your alveoli, okay? And that's how they work, right? They agonize beta receptors. You don't have beta receptors in your alveoli. So if you have somebody with pneumonia and they have a fever and chills and they've got crackles and they're coughing up green stuff, giving them albuterol is not going to help them, right? Unless the pneumonia is causing bronchospasm and they have associated wheezing, or you have evidence to suggest that they're having bronchospasm, then beta agonists are indicated. You guys okay with that? Obviously, getting an x-ray is going to be important, getting a chest x-ray, finding out where that consolidation is, all right? Get a culture and sensitivity of their sputum. Right, get a sample of it, send it to the lab. Getting them on antibiotics. And can we transport patients on antibiotics in New Mexico? Yes. They are within our scope. We cannot initiate antimicrobial therapy, but once it has been started, we can continue. So that's important. If you're transporting a pneumonia patient from one hospital to another, right, one of the core measures for pneumonia is getting them on antibiotics within a couple of hours of presentation to the ER, right? You would be negligent to transport that patient out of the sending facility if they have not received antibiotics, right? So that's one of the things you need to be careful about, right? The history and physical. Oh, there's a pneumonia. We've got a consolidation in the right lower lobe. Hey, doc, do you want to get some antibiotics going during the transport? Oh yeah, let's do them. We'll give a Grameracefin and hang some Levaquin or whatever the case may be. You guys okay with that? Mucus mobilization. Okay, this can occur. Basically, this is getting mucus out of their body, right? Helping them clear mucus. So this may be positioning them, right? This may be something known as TCDB, turn, cough, deep breathing exercises. And are you guys familiar with something known as incentive spirometry, or IS? Anybody who's had surgery knows that, right? What do you do with incentive spirometry? You blow into it?
Or no,
You don't
breathe
blow. Yeah, you don't blow, you suck with insinuspirometry. So insinuspirometry is inhaling. Why do we do that with patients who have had surgeries? To mobilize mucus, right? To help them clear mucus, to open their airways, to prevent and treat atelectasis. Same thing with pneumonia. We may do these kinds of therapies in patients that have pneumonia to help open their alveoli, to help mobilize and get rid of mucus. This can include things like CPT, chest physical or physiotherapy. This is percussive therapy where we're actually percussing them. A lot of the percussion is done pneumatically now, and you actually it's a little thing you hold that hooks into the wall, and you turn it on, and it actually percusses their chest wall. Some people, particularly cystic fibrosis patients, will wear a vest, and the vest will vibrate their whole thoracic cavity to break that mucus up and help them clear it. Okay? Turn, cough, deep breathe, insinuspirometry. Good. CPAP and BiPAP may be helpful if there is severe respiratory distress. Don't forget that. CPAP and BiPAP, right? Non-invasive ventilation may be an option for someone with pneumonia that is having distress. And it has been shown to decrease the need for intubation in advanced airway management. So, right, if we can prevent having to intubate somebody, that's a really good thing, right? Okay, you guys good with that so far? So good? So let's just talk about non-invasive ventilation real quick. So for non-invasive ventilation to work, the patient needs to be awake, oriented, and cooperative, right? They need to have a patent airway. They need to have some degree of hemodynamic stability, right? So far, so good. And they have to have no history of a recent pneumothorax. A pneumothorax is a bad deal, okay? And anytime you do positive pressure with a pneumo, it's a bad deal. All right, so what are the primary indications? Congestive heart failure exacerbation and acute pulmonary edema, right? That's one. You guys learned that in cardiology. Pneumonia is another. And believe it or not, asthma and COPD exacerbations as well. Right? Now, you think with asthma, which we haven't really talked about in great detail, asthma tends to be obstructive, right? It tends to be an airflow problem. And you think, well, if I'm giving you something that keeps your lungs open, wouldn't that be harmful? Can be, but it can also splint the alveoli open, splint those airways open that are inflamed, and actually increase airflow through those airways. And so, interestingly enough, non-invasive ventilation, CPAP, BiPAP, can actually be helpful to the asthma patient, and they also can help deliver inhaled medications more effectively in these patients, right? So you can get deeper penetration of medications and get that medication to those airways that need it. Okay, so that leads us into talking about asthma. Okay, people used to say that asthma was a form of COPD, but we now typically speak of asthma as a separate disorder, even though it has many of the same signs and symptoms as COPD, right? Airflow obstruction, hyper-responsive airways, increased mucus production, bronchospasm. The difference with asthma is that you have reversibility. Asthma is reversible. COPD is not. The damage that is done with COPD is done. COPD patients never get better, right? You can stabilize them and you can prevent them from getting worse, but they're never going to get over it. Whereas asthma, with good management, you can reverse it and lead a healthy life, right? So that's what separates asthma from other types of COPD. And you have these hyper-responsive airways, okay? And these hyper-responsive airways can be triggered into mucus secretion and bronchospasm. And what are some common triggers? Cockroaches are a big one, right? Particularly when the cockroach dies and its shell kind of flakes off into the dust. Dusts, pollens, exercise, stress, illness, pet and animal dander, household chemicals, and infections like pneumonias and upper respiratory infections. All right? Asthma is often associated with allergies. And anytime a disease is allergic in nature, it involves an allergic reaction, it is what's known as an atopic disease. So, for example, atopic dermatitis would be an irritation or inflammation of the dermis, right, the skin, due to an allergic reaction. Does that kind of make sense? Asthma and allergies go hand in hand. People that have lots of allergies or seasonal allergies or multiple allergies often are a little more prone to asthma developing. Okay, so what does asthma do when these triggers cause these hyperresponsive airways, or these hyperresponsive airways get triggered? Well, it causes wheezing and obstruction, all right? And we see that. We see respiratory distress, we see wheezing, we see increased rate, sometimes depth, right? Dyspnea, your classic asthma signs and symptoms. People that are seeing a doctor should have something called an asthma action plan. And a part of that is something known as peak expiratory flow rate monitoring, or peak flow. You guys familiar with the concept of the peak flow? Everybody diagnosed with asthma should have one of these. Should, okay? Not saying they will, but they should. You should use this when you treat them, if they have this available, okay? What this is this measures the amount of air, okay, that somebody, not the amount of air, but how quickly they can blow air out, right? And so it is based on your sex, whether you're male or female. It's based on your height and your age. And so I had this one set up for me back when I was 35. And you can see that this tape is kind of old looking. So I wasn't 35 recently. That's basically what that says there. So what you do is, if they have this, part of their asthma action plan, just remember it's 3 colors: green, yellow, red. Green means good airflow. Yellow is caution. You need to stop. You need to administer a rescue agent, right? And then red is critical. This is someone who's critically ill, okay? They need to go to the hospital. They need admission. All right, so what you do is you reset the device. This particular device, I just go like this, swipe it down to reset it. Your patient needs to be sitting up, and it is the best of 3. All right, so they take a big breath in, they lock their lips around this, and they blow out as forcefully as they can 3 times. And what you will happen is there is a little, in this case it's a little yellow line there. You guys see that there? And that little yellow line gets blown up, and this is their flow, okay? And you can see the flow, but what we're really looking at is the color. Where does that land on? So that's 1, right? That's 2, right? And 3. And then so you do all 3, you don't reset it, right? You just do all 3, and whatever the best of the 3 is. And so you can see that this is landed right in the very top of the yellow, bottom of the green here. So I'm kind of in that caution zone today, right? Well, yeah, but I'm a little older today than I was when this was done on me. So I'll just kind of pass this around for you guys to take a look at. There are many different types of peak flow devices. That's just one device. But you should be aware of it. You should use it and document those findings. And really, it's the color that you're most interested in. Each peak flow meter has to be set up for each individual patient. Okay, so initially, what do we see with these patients? Initially, we're going to see a respiratory alkalosis, believe it or not, if you were to run an ABG on them, right? They're going to be breathing fast and deep, and they're going to be blowing off CO2, and they will look like they're in a respiratory alkalosis, which they are. And the respiratory acidosis and the low pulse oximetry and all that is a late finding in an asthma patient. If you see that in an asthma patient, that is someone who's very sick. Okay, so just kind of keep that in mind. So, how do we treat asthma? Well, I have a general little flow or an algorithm, if you will, here. So how do we treat it? If it is a mild to moderate, okay, so basically you have mild to moderate signs and symptoms, awake patient with an intact airway, start with supportive care, get a peak flow on them before you treat them. So pre and post treatment peak flows, get them on side stream in CO2 monitoring, right? See what the waveform looks like. Give them oxygen as needed, and give them rescue drugs, SABAs, short-acting beta agonists, i.e. albuterol or Zopanex. I'll leave albuterol. Okay. You can also add an inhaled anticholinergic to that if you want. Okay, ipratropium being the big one, right? Give them fluids as they need it. Oftentimes asthma patients can get dehydrated, particularly kids. And then follow it up with a steroid. All right, that's standard treatment. All right, you guys okay with that? And then you just closely monitor and reassess them, get them on cardiac monitor, frequent vitals, get an H&P and all that. You guys cool with that? Now, what is status asthmaticus? Yes, so this is an asthma attack that does not respond to rescue therapy, to short-acting beta agonists, right? And some history that you want to get in your patients, right? Does your asthma patient, how many times have they been in the hospital? If they've been in the hospital more than once a month, that's problematic, right? If they've had to go to the ER more than once a month, that's problematic. If they're using more than one of their MDIs a week, that's problematic. If they have a history of intubation, that's problematic, right? So these are questions you want to be asking. How much of your inhaler are you using, right? Oh, I'm going through a canister a week. That's a lot, right? Have you been to the ER this month? Oh yeah, I've been to the ER 3 times. Okay, this is problematic. Have you been hospitalized? Yeah, I spent 3 days in the hospital a couple weeks ago, right? These are all very problematic. So what do we do? So if you suspect status, okay, treat the ABCs, obviously. Bag a neb in. Okay, you guys all know how to bag a neb in? Have you ever done that? Okay, remind me, and during lab today, I will show you how to modify a BVM so you can bag a neb in. So it's a skill you might use. CPAP and BiPAP may be helpful in these patients, right? May help stabilize them, splint their airways open, and help with better delivery of medications. And continue rescue drugs, right? So give them multiple doses if they need it. In the hospital, sometimes what we'll do is what's known as an hour-long treatment, where we'll give them 20 milligrams of albuterol in an hour, right? In a large volume nebulizer. Epinephrine, right? 0.3 milligrams IM, so we treat them somewhat like anaphylaxis, right? IM epinephrine. Magnesium sulfate is a third-line intervention. So rescue drugs, continue to give rescue drugs, add epinephrine into the mix, and consider magnesium sulfate, right? 1 to 2 grams over 20 to 30 minutes, right? It's standard, right? Intubate them as a last resort, okay? Intubate and positive pressure ventilation as a last resort. And we need to know that if you are doing positive pressure ventilation or you've intubated your patient, you need to allow for prolonged expiratory phase, right? Several seconds for them to exhale. Sometimes you literally have to put your hands on their chest and push it in to get them to exhale. You can actually cause them to go into cardiac arrest by bagging them due to the air trapping, right? That can happen with these patients. In the hospital, sometimes what they'll do is they'll do heliox therapy, right? And why would heliox therapy be potentially effective? Well, helium is a much smaller molecule than nitrogen, right? Most of what we breathe in the air is nitrogen. Nitrogen is much larger. So heliox is less dense, it's much smaller, and heliox can get through constricted airway passages a lot easier than the air that we normally breathe, right? Nitrogen, oxygen. So heliox may be administered as well. Okay, you guys okay with that? Kind of making sense? Okie dokie. I'm going to stop here because ARDS is a whole discussion all of its own. So I'll stop here.